I was asked to briefly talk about the definition of stereotactic radiosurgery, and I thought that beside the definition, what is really important to me is the concept of a team, and then to touch upon three of the benign CNS tumors that are frequently treated with SRS: pituitary adenomas, acoustic neuromas, meningiomas, and finally touch upon metastasis. And all this needs to be done in less than 20 minutes, so we have to move along rather rapidly. What is SRS? Well, SRS can be defined as a minimally invasive technique used to deliver a single high dose or up to 5 doses to a limited, well-defined target volume while avoiding nearby normal tissue and critical structures. Safety and efficacy are the key of SRS, the use of highly conformal dose delivery that results in steep dose fall-off in the adjacent tissue. And as we heard from Glenn, there are different devices that can be used depending on the energy that is delivered, photon or cyclotron. And most of the centers that are doing SRS are using either a gamma knife or a Linac-based accelerator. Although the gamma knife is the first one that has been used for SRS in the past 10 years or so, I think that the Linac-based technology is the one that has expanded a little bit more in adding some fancy tricks. And the concept of all these machines is that there is a sharp dose gradient fallout. How does a Linac work? Well, it's a pretty straightforward power supply that is generating that is activating an electron gun. The electrons are accelerated through a tube and they are spit out on the other end through a secondary collimator, and those collimators can be changed in size. And recently, some of these machines have added other features, such as a robotic arm and the possibility of inverse treatment planning, the possibility of using image guidance to track the movement of the patients, as well as high-speed computing, and this will be a cyber knife. Or alternatively, a Novalis, where there is image guidance tracking for patient's movement, where there is ExoTrack at the time of treatment. And in both cases, with the CyberKnife and or the Novalis, the entire body can be targeted, brain and spine. The stereotactic radiotherapy, on the other hand, is a modality that allows us to deliver smaller doses that are delivered over a longer period of time. And for benign tumors, very often we go and discuss the advantages of SRS versus SRT as we are in close proximity with structures or organ at risk. So what is going into the equation of deciding between SRS and SRT? I think that the most important thing is to determine the risk-benefit ratio, and this is why I think a team approach is quintessential. The way in which I see the radiosurgery team in a very simplistic way is one where there are basically two pilots, a radiation oncologist and a neurosurgeon, that cannot exist unless a very highly trained and specialized other component of the team is with them, physicists, technician, and nurses. And then naturally all this is discussed in a forum, weekly tumor board with the neuro-oncologist, the neuroradiologist, the neuropathologist, and the oncologist. And it's only because of the effort of these individuals that I think we can choose the best and the safest plan for each patient. Pituitary adenomas, historically, Dr. Lexell treated the first patient with a pituitary adenoma. A pituitary adenoma was the first patient ever treated with radiosurgery by Dr. Lexell. The treatment of pituitary adenomas is typically medical, and in fact, some of the pituitary adenomas will never require a neurosurgeon. Prolactinomas are treated medically beautifully, and only occasionally they come to our attention. And when they come to the attention of the neurosurgeon, typically they are addressed with surgery. However, some of the active tumors do involve the cavernous sinus, and some of the non-secreting tumors do involve the cavernous sinus as well, and therefore surgery alone cannot be a cure, and radiation can be offered. Radiation can be offered in different forms. And what are the goals? Well, the goals are for the non-secretory tumor, radiographic control, and we want to make sure that the symptoms that the patient is presenting with are not worsened by the treatment. For the secretory tumors, not only radiographic control is desirable, but hormonal control is very important. Side effects that we want to avoid with the treatment: hypopituitarism, optic neuritis, and or other deficits to the optic apparatus, and deficits to other cranial nerves that are in close proximity either with the tumor or the extension of the tumor in the cavernous sinus. And we have multiple alternatives for these tumors. We can use the conventional external beam radiation, SRS and SRT, or, as Glenn explained, IMRT. When we look at the data for external beam radiation of non-secreting pituitary adenoma, we see that basically the control rate is very high, and however, the hypopituitarism can be as high as 42. So although the control rate is high, the toxicity, especially the late toxicity, is probably something that would make nowadays a patient and a physician to shy away from the external beam radiation. On the other hand, a radiosurgery, when we look at the radiosurgery, we still have a very high control rate ranging from 100% to the high 90s, and the rate of hypopituitarism significantly lower in the 20s. When we look at the SRT, similarly, the control rate remains really high, and the rate of hypopituitarism is also much less than with external beam radiation. So here's a case. This is a 54-year-old man with a secretory pituitary adenoma presenting with bitemporal hemianopsia, status post resection in 02, and subsequently MRI demonstrated progression of the disease, underwent a repeat resection 4 years later, and there was still a residuum that was in the cavernous sinus. And this was treated with a single fraction radiosurgery, and patient continued to have good pituitary function and persistent radiographic control 4 years later. Here's another example of a much larger tumor, 45-year-old man with a non-secretory pituitary adenoma. He also had a transphenodal resection, and in this individual, we prefer to use SRT with a total of 50.4 gray, as the volume was much larger. And this individual also continued to have persistent radiographic control on 5 years. He presented with hypopituitarism, and his hormonal level was unchanged after the SRT. Looking at secretory pituitary adenoma, because we only have a few minutes, I can't go through all the hormones, so I picked GH. And for GH, I just give you the biochemical control, which is the normalized as age and sex adjusted IGF-1 and GH. And so when we look at external beam radiation, we see that the remission is at 10 years is pretty high. Biochemical control is approximately 55%. And when we look at the hypopituitarism, however, we see that it goes all the way as high as 80% in 2 series. And here we go. And here instead is the radiosurgery data, again, just for one of the secreting tumor, the same one, GH. And when we look at these series in the slide, we see that the biochemical control remains pretty good, and the hypopituitarism is significantly less, ranging between 10 and 33%. When we look at the stereotactic radiotherapy data, this is pretty scanty because it's not being used very frequently. This last paper is ours, and basically you can see that the biochemical control seems to actually be even a little bit more favorable, although the follow-up is less than SRS. And the hypopituitary problem complication is very, very low. So very promising. Still need to acquire more data and more centers to use it. Now let's jump to vestibular schwannomas. Vestibular schwannomas are benign tumors, and the most important concept for these tumors is that they have a relatively benign natural history. As this paper showed many years ago, 40% of this tumor do not grow. So if they do not grow, they should not be treated. And this is a very difficult concept, I think, sometimes to discuss with patients because they're sent to the radiosurgeon or to the neurosurgeon, I should say, and they really need something and they want to have it done. And I think that the first thing is really to tell them, well, this is the first MRI you ever had. It's a very small intracanalicular tumor. Why don't we see what happens next? And typically in my institution, we only treat patients with very small tumors if there has been radiographic progression and or progression of symptoms. What are the options? I think that the options are surgery and radiosurgery once that we show that the tumor has been growing and or the symptoms have been getting worse. And the goals are twofold: radiographic control, but very important, hearing preservation for those patients that still have usable hearing. As you see on this side, the majority of patients with vestibular schwannoma do present with hearing loss, but some patients still have very good speech discrimination when they come to our attention. And so let's focus a little bit on the surgical data just for a minute in very good hands, such as those of Dr. Post. You can see that if the tumor is less than 1.5 cm, you have a post-surgical hearing that is 49%, and if you add it both together, it's 53%. When you go from 1.5 to 2, it's still in the high 40s, 50s, and then it significantly drops down when it's greater than 2 cm. Dr. Young et al. Presented a paper in Journal of Neurosurgery of 2010 looking at data from PubMed, and they were able to put together 4,234 cases. The hearing was intact in over 1,000 of those cases, and they showed that hearing preservation with radiosurgery was present in 51% of the cases. What was interesting was that when the high radiation dose was used, and that is more than 13 gray, the hearing preservation was much less favorable than when the dose was decreased to less than 13. Additionally, what they showed was that in the radiosurgery literature, differently from the surgical literature, hearing preservation is independent of tumor size when looking at tumor of 1.5 centimeter. And the other interesting thing is that hearing preservation was independent of age, although it looked like some of the older people did slightly better, but it's not statistically significant. And so here are a couple of cases. A 48-year-old man presenting with vertigo and decreased hearing on the right side. And this tumor we treated with a single fraction. Before radiosurgery was 25 millimeters, 14 months later, 19 millimeters. Again, for the radiosurgery, the concept is really not to shrink the tumor or to make it disappear, but it is a radiographic control. And this is another important concept to discuss with the patient and referring physicians. Here is another case where an 11-year-old girl with NF presented with bilateral hearing impairment. The right side was greater than the left, and we gave her 12.5 in one fraction to the right acoustic neuroma. You can see her acoustic was 14.2 prior to radiosurgery. 6 months later, it got a little bit bigger as the center of the tumor is more necrotic. And then at the 14 months, the tumor is a little bit smaller than before radiosurgery. And this is a typical scenario that we see in over 30% of patients, that if you scan them before the 12-month interval, you do see some radiographic enlargement due to the necrosis as a desirable effect of the radiosurgery. Now, what about stereotactic radiotherapy for vestibular schwannoma? There are multiple series, and the one that is summarized in this slide is from Mass General. The subjective hearing preservation rate in this series was excellent, 84% at 3 years. And I think that this sort of sparks some interest to look into whether or not the stereotactic radiotherapy can give a better hearing preservation than the single fraction alone. The question is still on the table, and additional studies need to be done. This is a case that we treated with stereotactic radiotherapy. The patient is a 30-year-old man who underwent subtotal resection of the right acoustic neuroma. This was rapidly growing, and we treated him because of the size and the effect on mass effect on the brainstem. We treated him with SRT, and this is his scan 24 months after SRS. Again, promising data, but still necessary to validate that the hearing preservation is better. However, we now have patients that are reading the data online and that are presenting to us. This is a 34-year-old opera singer. She only has headaches. She had an incidental MRI finding because the MRI was done for headache, and she has a speech discrimination on the right that is 100, on the left is 98, and she's telling us, but you know what, doctor, I read that with stereotactic radiotherapy I might have a slightly better chance, so I would like to go for that. And in this particular case, she was treated. We treated her with the stereotactic radiotherapy. It says radiosurgery, but it is SRT, and her speech discrimination remained unchanged at the 36 months. Meningiomas, other benign tumors. When can we use radiosurgery for meningiomas? I think if the size is less than 3 cm, if they are not located in close proximity with the optic apparatus, and if they are, we can use SRT. And the results are showing that the long-term radiographic control is excellent, 93 to 100%, depending on the series. Here you see a case that we treated. And here you see some data. There are multiple papers on this topic, and you see that the 5-year lack of progression goes as high as 100% in these patients. When do we use SRT as opposed to SRS? Well, I think that any time that the tumor is abutting or it is involving the optic nerve, we prefer to use SRT. Here you see the treatment plan, and here you see 4 years later, he is not even coming to us anymore. He's sending us outside films. This is why it's so poor. The resolution is poor, and you can see that the tumor achieved radiographic control and, in fact, some shrinkage as well. And finally, metastasis. Metastasis, I think that are the first tumor that, or one of the first after the pituitary for Dr. Isabelle treated. They've been treated successfully with radiosurgery many years ago in 2000 when I put together the book comparing Gamma Knife and Linac, showed that there is really no difference in using these two technologies for freedom from progression, and depending on the studies and depending on the dose that was delivered, they range between 62 and 95%. And if we look at the more recent literature, I think that we are in the high 80s across the board. So radiosurgery is highly successful for metastasis. Now, the goal, again, is not removal of the tumor, but it is the radiographic control. And typically at 3 months, the control is very close to 100, and then it goes lower as we move away from the treatment. It's also important to remember the histology of the tumor makes a big difference, and the systemic disease makes a significant amount of difference. In this slide, we show here a response in 4 weeks or a little bit less, where we go from this lesion to a ghost lesion, so quite rapid and dramatic response. For other tumors, such as this one, a neuroendocrine tumor, you see that basically you are left with a little dot at the 6 months, and the lesion is virtually gone. For tumors like this one in the brainstem, I think that the radiosurgery is an excellent option because it can target just the lesion itself, and breast is highly sensitive. And as you can see at the 6 month mark, there is really no evidence of that tumor anymore. And for multiple metastases, like in this case, 1, 2, 3, and I think she actually had more than that. But you can see that it's an excellent way to treat, and we can discuss if it's a good idea to treat all 3 at the time or sometimes you treat the most complicated and then you bring the patient back and do the other two. I think that that's a little bit of dealer's choice. And for other tumors that have been historically refractory to radiation, such as melanoma, radiosurgery single fraction is excellent. You can see the top before and after 4 months. You still see a little shadow here, but the other lesion does not appear in the scan. For metastasis, we have a lot of different questions, however, that do not necessarily revolve around whether or not radiosurgery is efficacious as a treatment, but whether or not radiosurgery is better than surgery, whether or not radiosurgery should be used with whole brain radiation, without whole brain radiation, prior to whole brain radiation, should we give a radiation to the surgical cavity, and so on and so forth. And I think that the best paper that just came out in Journal of Neuro-Oncology by Dr. Linsky and Dr. Kalkanis is this one. The title is The Role of Sterotactic Radiosurgery in the Management of Patients with Newly Diagnosed Brain Metastasis, a Systematic Review and Evidence-Based Clinical Practice Guideline. And as you can see in the slide, the target population is very well specified. And basically, the recommendations are that there is level 1 evidence that single-dose radiosurgery along with whole brain radiation leads to significantly longer patient survival compared with whole brain alone for patients with a single metastatic brain tumor who have a Karnofsky performance score greater or equal to 70. And it's interesting to always look at this KPS because in most of the tumor literature, KPS has a significant role. Level 2 evidence-based guideline is that a single-dose SRS with whole brain is superior in terms of local tumor control and maintaining functional status when compared to whole brain alone for patients with 1 to 4 metastatic brain tumors, again with a KPS equal or greater than 70. And level 3 evidence, single-dose SRS with whole brain might lead to significantly longer patient survival than whole brain XRT alone for patients with 2 to 3 metastatic brain tumors. And there is no mention of the KPX for this recommendation. And finally, level 4, there is class 3 evidence demonstrated that single-dose SRS with whole brain is superior to whole brain alone for improving patient survival for patients with single or multiple brain metastasis and a KPS less than 70. So with this last slide, I would like to just conclude saying that stereotactic radiosurgery is an excellent treatment option for benign CNS tumors such as pituitary, vestibular, schwannoma, and meningiomas. And naturally, it is a great option for brain metastasis. We still have quite a few open questions: surgery versus SRS. For a single lesion, which of the two treatment is best? There is no prospective study, a randomized perspective that has been conducted. Surgery versus surgery and or SRS for multiple lesions. We know that for multiple lesions, if you do surgery on all of them, it's better. The survival and the quality of life is better than if you don't treat them. But what about doing one surgically and the other 2 or 3 with radiosurgery? Is that equipoised to surgery alone? Again, we don't have the answer yet. And then finally, SRS boost to the surgical cavity. Is that something that should be done or can be done? And where is the data to support that this is beneficial? And I think that this is my last slide. Yes. Here we go.
Isabelle, that was fantastic. Thank you. Let's move right to the polling questions, and we'll put up this first question here, which is external beam radiation therapy was offered as adjuvant treatment for secreting pituitary adenomas. Recently, SRS and SRT can be considered as alternatives. Which of the following is true? A, hypopituitarism is less common with SRS than SRT. B, hypopituitarism is less common with external beam radiation than SRS and SRT. C, hypopituitarism is less common with SRS and SRT when compared to external beam. Or D, hypopituitarism is the same with SRT as it is with SRS. You can take a moment to answer the questions to the right, and As you're doing so, just like to remind everyone again, if there are any questions that you have for any of the faculty, you can direct them to me or to the individual faculty members. And also there will be a blog in the next few days, which I'll receive a link to as part of your participation in this session, so that you can participate in more online question and answer sessions as well. You'll get CME credit for tonight's event, and it will allow us to generate important information from this whole experience. So more to come on that in just a few minutes after Dr. Kanziopa's talk. But if we can get the polling answers ready, David, we'll put those up shortly. And then Isabelle, maybe you can go through the question and tell us.
So the preferred answer is C. Hypopituitarism is less common with SRS, SRT than external beam radiation, and I see that 50% of the people that answer got it right. Now, whether or not it is the same with SRT and SRS is still debatable, but it seems like this is not the case. And answer A, less common with SRS and SRT. Again, it seems like this might not be the case, although additional studies are necessary. And finally, B is wrong because it's exactly the opposite of the correct answer. The correct answer is C.
Great. Perfect. All right. Well, let's go on to the second question, which has to do with the guidelines for brain metastases that we just published, and I'll read it off as you have it here. Level 1 evidence-based clinical practice guidelines for the role of stereotactic radiosurgery in the management of patients with newly diagnosed brain mets. These are newly diagnosed lesions. Include the following. In other words, which of the next four statements is true? A, SRS plus whole brain results in longer survival when compared to just doing whole brain radiation therapy alone for patients with a single MET and KPS less than 70. Or B, SRS plus whole brain results in longer survival than whole brain alone for patients with 2 to 3 METs and KPS less than 70. Choice C is SRS plus whole brain results in longer survival than whole brain alone for patients with 2 to 3 METs and KPS greater than 70. Or D, SRS plus whole brain results in a longer survival time when compared to whole brain radiation therapy alone for patients with a single MET and a KPS score of greater than or equal to 70. Again, if I could ask everyone to click the polling answers on the lower right section of your screen and submit it, we can tabulate those results. And while everyone's doing that, Isabelle, perhaps I can turn it back over to you and start by telling us why some of the answers are not correct, and then.
Okay, so the correct answer is D, and we highlighted the fact that a Karnofsky greater than 70 or equal to 70 is important. So if you look at answer A, it will be a level 4 evidence and not level 1. And if you look at B and C, those have to deal with patients with more than one MET, and for patients with more than one metastasis, the level is 3 and it's not 1. And
Perfect. So it looks like just about everyone who answered the question got it right. So that's a great job to all.